Hello to everyone and welcome back to my channel. My name is Tommy. I'm a human nutrition student and researcher at the university. What I do in these type of videos is to synthesize the classes of the university and then I explain and teach you the best and most valuable information you need to know. Today we're going to continue the Dietotherapy series of videos and we're going to talk about the diet with the modification of minerals and vitamins and water. So let's begin. We have the diets with mineral modification, in which we, for example, change the sodium quantities. Low sodium diets for people who have high blood pressure. Hypertension is when you have more than 160/95. Normal tension is below 140/90. The borderline hypertension is in between the above two, so if you have more than 140 but less than 160 and more than 90 but less than 95. And then there is also the added risk hypertension, which is where we have higher than 130/85. Basically, we say that hypertension, it affects the heart, the brain and the kidneys. 90 to 95% of the people who are hypertensive, the cause is idiopathic. So they say that they don't know exactly what is the cause of the high blood pressure. They think it is correlated with sodium. Therefore, the EFCA limits the consumption of sodium to 2.4 grams per day. That's around 5 grams of salt per day. And there are some recommendations to give to these people to, for example, swap the salt for spices and condiments. This is to mimic the salt because salt gives a lot of taste to the food. And also to eat potassium-rich foods because potassium, it is correlated with a lower blood pressure. Also, some general recommendations for these individuals are to lower weight, exercise of course, limit the alcohol and lower as well the coffee and tea consumption, even though there are no studies that determine a clear correlation between coffee and tea and high blood pressure. Diets that change the calcium intake. Calcium is the most abundant mineral in the body. So we have 3 diseases here that have to do with calcium. The first one is the renal lithiasis or kidney stones. 4% of the population have kidney stones. The majority are males over 30. And the etiology of the kidney stone can be primarily because of calcium oxalate, calcium phosphate. These two are together the majority of the times. Then uric acid, the struvite and the cysteine. But the main ones have to do with calcium, as you can see. So oxalates, calcium oxalate 70% and calcium phosphate 6%. Crystallization processes occur because of these 3 things. First one, the solute saturation of the urine. So there is a hypercalciuria, so high calcium in the urine. The second one is due to low crystallization inhibitors. And the third one, changes in pH. Remember that acidity will create corrosion of the crystals. So if we have an alkaline urine, chances are these crystallization processes can occur even faster. So high oxalates and higher proteins, as well as higher vitamin C is correlated with oxalates and the kidney stones, as well as high calcium and low citrates and low magnesium will indeed cause kidney stones. The solution to this is to drink a lot of water, of course, lower the weight, maintain the proteins in an adequate quantity but not too high, lower the salt, increase the citrate and the magnesium, these are present in veggies, lower the stress, lower the oxalates to 100 milligrams a day, and we have to lower the calcium quantities only in the phosphocalcic alone. When there is only the calcium phosphate kidney stone alone, when it is combined, we do not lower the calcium. We have to lower the purines when there is the uric acid lithiasis, and we have to lower the phosphorus and the magnesium in the struvite lithiasis. Now we talk about osteoporosis. Osteoporosis is due to lower mineralization and lower bone volume. There are 3 types: the primary, the secondary and the idiopathic. The primary type 1 is due to low estrogen levels. This happens in the menopause in women. Primary type 2 is due to age. Secondary is due to disease or drug treatments. And the idiopathic, unknown origin. So what does the osteoporosis cause? Acute pain, hip fractures and bone deformities. What do we have to keep in mind with osteoporosis? The body weight and the composition of it. We have to increase the muscle and reduce the fat. The calcium-phosphorus ratio is always very important. We tend to eat a lot more phosphorus than calcium, where the ratio should be 0.5. Vitamin D3, very important with bones. Vitamin K, because it helps mineralization. The high protein diet and high sodium diet will increase the calcium lost in urine and therefore will not help us with osteoporosis. And also fluoride, with the fluorohydroxyapatite, it's involved in bone formation. Adequate calcium intake throughout the life. This is very important throughout the entire life, because trying to compensate in the old age is not helpful. So you have to consume your daily calcium, around 1 gram. Increase the magnesium intake as well and do physical exercise. Cardio, strength and mobility movements. These three will all stimulate the bone formation. Then we have the rickets and osteomalacia. This is low bone mineralization. So as you can see, the volume stays the same. This is the difference with osteoporosis. Bone volume here stays the same. Rickets in children, osteomalacia in adults. It is basically a slowed new matrix formation. The primary causes are because of low vitamin D, either from the intake in the diet or decreased skin synthesis. Secondary causes are problems of absorption or metabolism of the vitamin D. So diets with mineral modification of iron, iron deficiency, anemia. It is a decrease in hemoglobin quantity. We have 4 successive stages. The first one, we lower the iron, nothing else. In the second one, there is low iron and also low ferritin reserves, because we can accumulate a little bit of iron in our body. The third one, we decrease the red blood cells production. And the fourth one, there is low hemoglobin and therefore anemia. Causes, you don't eat enough iron, maybe because you follow a vegetarian or vegan diet, or you don't eat red meat. Or maybe because you need more at certain stages of life. For example, when we are growing, we need more iron than normal. Or maybe because you lose too much blood via menstruation, hemorrhages, or infections. We need to eat around 12 milligrams of iron a day, more or less. Only 1 milligram of those is actually absorbed though. What are the recommendations for these individuals? Change their diet. Liver contains a lot of iron, legumes plus vitamin C, this is for the higher absorption of iron. Avoid anti-nutrients that can reduce absorption. And be careful with antacids and antibiotics, because these two also block the iron absorption. Iron supplements, if needed, and fortification of foods with iron. For example, flours, salts, and cereals. You can find them if you look for them. Then we have copper deficiency. Copper is an enzyme intermediate. Copper creates problems if there is a deficit of it, but also if there is an excess of it. This is the Wilson disease. Fructose and zinc can lower the copper absorption, and the real problem though is not the interaction with other nutrients, it is the low intakes in the diet. You have to know that copper has to do with electrons. No copper, no iron transitions. No hemoglobin, no ferritin, no erythrocytes. So basically, we can get an anemia because of copper, and copper is the guy that changes the electrons when needed. That's why we use copper fields for our electricity. Think about that. EFCA says that we need to consume 1.3 milligrams per day in women and 1.6 in men. And copper is found in oysters and mollusks, as well as nuts and cereals, grains. Diets with vitamin modification. Here we have the megaloblastic anemia and the vitamin B6 deficiency. Megaloblastic anemia is the decrease in DNA synthesis. It has to do with 2 vitamins that are the gene expression vitamins. The vitamin B9 or folate and the vitamin B12 or cyanocobalamin. Cobalamin deficiency, blood cell formation and folate metabolism. This is what the vitamin has to do with. Causes insufficient intake, vegans, gastric disturbances. This is, for example, when there is no intrinsic factor for the absorption of it in the colon. Intestinal disturbances and no separation of proteins, because the vitamin B12 travels together with proteins. And interactions with drugs and alcohol. In the stage 1, we have a reserve, fortunately. There is a serum depletion though. Stage 2, tissue depletion. Metabolic pathways not altered yet. Stage 3, insufficient tissue deposition. Reduced DNA synthesis and erythrocytes with lower folate. In the stage 4, we have metabolic disturbances. These create clinical damage, but this is corrected with only 5 micrograms of vitamin B12. This is really impressive. We find vitamin B12 in bacterial synthesis in our microbiota in the colon, and only in animal sources, animal foods. Viscera, liver is full of vitamin B12, meat, egg yolks, salmon, and dairy products. The recommendation is between 2.4 to 4 micrograms. So as you can see here, we do not give a super high dose to correct the deficiency. On the other hand, the folate deficiency. Folate is a structure of pteroglutamic acid, the folic acid. The causes of the deficiency are because of insufficient intake, because of the age, high requirements. In pregnancy, we need more folate, decreased intestinal absorption, or metabolic disturbances, alcohol and vitamin B12 deficiency. As we talked about here, erythrocyte, lower folate in the erythrocytes because of vitamin B12. So vitamin B12 has to do with folate. Again, these are all connected. Stage 1 of the deficiency, no cellular depletion, but serum depletion. So as you can see here, the same thing happens. We have a deficiency first in the blood. No metabolic alterations. Stage 2, erythrocyte folate decrease. This is the same thing that happens here. The folate in the erythrocyte decreases. Stage 3, impaired erythropoiesis. Not enough DNA produced. Stage 4, megaloblasts macrovalocytes and reduced hemoglobin. We find folate in monoglutamates and polyglutamates. Monoglutamates, 90% of them are absorbed and they go through direct absorption because they are mono, so easier to absorb. Poly, more than one, they have to be hydrolyzed to be absorbed and only 50% can get through. And we find folate almost everywhere, mainly in veggies and legumes. On the other hand, we have vitamin B6 deficiency. Vitamin B6 is the pyridoxal phosphate, and it has to do with amino acid metabolism. If you remember from last year's videos of regulation and integration of the metabolism, I explained the amino acid metabolism and the pyridoxal was there. Go check that out if you don't remember it. Rare in modern countries, the deficiency. It is caused by cereal-based food because these are very rich in glucoside, but it's not absorbable. Also because of chronic alcoholism, lower phosphorylation and higher dephosphorylation, treatment with various drugs, interaction between them, and chronic hemodialysis. The recommendation is between 1.3 to 1.7 milligrams a day in men and from 1.3 to 1.5 milligrams a day in women, so a little bit less. We can find it in liver, legumes, nuts, and bananas. And we have to be careful with this vitamin because it is very fragile. Thermal processes increases the losses up to 50%, so be careful with heat. Then we have diets with water modification. Without water, there is no life. And it is involved in digestion, absorption and excretion, transport and elimination of nutrients, also the body temperature regulation, osmotic balance of salts, and pH as well. Water is also involved in cell shape and lubricating fluids. The water balance. The total water intake, we say, is the one from food and beverages. Intake. The available water, though, is the intake plus macronutrient oxidation. Water losses. Renal losses, high protein and high mineral intake, and diabetes and diuretics will increase the urine. So a lot of losses through the kidneys. Cutaneous and pulmonary losses, body temperature and environment, will change our respiration and our sweating. Gastrointestinal losses, for example in feces, diarrhea and vomiting, and there is another thirst sensation. And you have to know that when you are thirsty, you're already a little bit dehydrated. Dehydration types. By amount, it can be mild, when you lose about 1 to 2% of your body weight, moderate from 3 to 5, high from 6 to 8, and severe from 9 to 11. Over 11, it is incompatible with life, so you cannot really live anymore. By speed of loss, if it is sudden, it has more severe symptoms. By lost solid water ratio, we have isotonic, when we lose the same amount of water and solids. Hypertonic, when there is more water lost, so our own body remains hypertonic. Or hypotonic, when we lose more minerals and therefore we are left with more water. On the other hand, we also have the water intoxication, which is drinking more than the maximum renal excretion, which is about 0.7 to 1.1 liters per hour, depending on the individual. Many studies suggest that this is around 0.75 in the majority of them. Water intoxication causes hyponatremia and possible cerebral edema. So which one is the adequate water intake? We say 1 milliliter per calorie per day. So if I eat 2500 calories in a day, then I have to drink 2.5 liters. And you have to adjust more water in children and athletes. You have to replenish the water lost 1 liter per lost kilogram. And also in pregnant and breastfeeding women and in the elderly. Pregnant women because they need water for the fetus, indeed. Breastfeeding women because they need water for the milk production, and in the elderly because they lose the first sensation and they dehydrate much faster and easier, so be careful with that. Okay, so that's it for this video. Thank you so much for watching. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to like, subscribe to the channel, and share this video to your friends and family. Thank you so much for watching again, and I will see you in the next one. Ciao!